All right, well, I'd like to take this time to introduce our webinar today, and thank you all for joining. This is John Patton. I'm the Director of Communications for the National Association of Chronic Disease Directors. And today we're going to be hearing about a brand, well, it's nothing new actually in the world of technology, but it may be new to many of you and certainly was to us. About a year ago when we learned about Kognito through some mutual colleagues through our Achieve Community grant funding opportunity. And so we found out that in fact, we're having a little bit of a feedback here. See if that helps at all. May just be on my end, so I'll just continue, but feel free to jump in if it's
we can hear you well, John.
Okay, very well. So once we got together with Kognito, we learned that there would be many applications for the chronic disease community. Now, Kognito's been around over 10 years and has been enjoying great success with VA, with SAMHSA, with substance abuse, working with public high schools, with CMS, with DOD, and you'll see the many applications that are obvious in those arenas, but I think you'll quickly see all the applications for chronic disease. We have begun conversations with them in the area of prediabetes, and as they'll also tell you, the behavior change, as you know, often comes when a doctor tells a patient what they should do. And oftentimes those conversations need a little bit of jump starting, a little bit of training and coaching, and that's where Kognito comes into play. You may have seen things like this. We've never seen anything remotely as science-driven as Kognito is. They are just steeped with the deepest psychological and sociological science behind everything they do, and I don't know if our webinar will have enough time to share all the features and the depth of the talent of this technology, but we want to get right to it. I want to mention that we'll have 3 speakers today, as you've seen in your invitation. We're going to be led by Allison Baker, who's the Director of Division of Safety and Health Promotion at the American Academy of Pediatrics. And Allison's worked with Kognito. She knows firsthand how effective they are. And we'll also be hearing from the 2 co-founders of Kognito, Glenn Albright, the founder and director of research, a clinical psychologist affiliated with City University of New York, and also Ron Goldman, the co-founder and CEO, who's an innovator, tech executive, and social entrepreneur. And just everyone is riveting to listen to and engaging, and I know that this is going to be an excellent hour together. So without further ado, I want to just run through our agenda. Today you'll learn about the Institute for Healthy Childhood Weight and Kognito, just an intro. The challenge with changing health behaviors, much of what you already know and experience. The power of conversations in changing health behaviors, and then using virtual humans and their benefits compared to in-person and video. This, to me, was very interesting, the significant benefits of virtual humans over video. And then ChangeTalk, which is an example of a conversation centered around childhood obesity, a great case study. And then there will be some time for question and answer. And if we're running short, everyone has agreed to being able to have the questions forwarded to them, and they'll get back to you. So do jot them down as you listen. And now I would like to turn it over to Allison. Thank you very much for joining us today.
Thank you so much. It's a pleasure to be joining you today. I'm here today representing the American Academy of Pediatrics Institute for Healthy Childhood Weight, which we launched in 2013 really to focus on translating obesity-related policy and research into practice in American healthcare communities and homes. And as you can see here, specifically our focus is to empower pediatricians, families, and children to better prevent, assess, and treat obesity and its comorbidities, to enhance partnerships with families. We do see this very much as a partnership with families to find and navigate their own individual pathways to healthy active living. And then finally, to catalyze stakeholders and communities to build and enhance capacity for healthy active living. We recognize there's a tremendous amount of work already underway in communities, great work that's underway. We do not intend to duplicate that, but really to prepare our pediatricians and members to be able to take part in some of those initiatives. Initially, we're focusing our efforts on early obesity prevention, specifically pregnancy through age 5, and on obesity treatment, which of course is critically important given the 30% or so of children and youth already dealing with obesity.
Thank you, Allison. This is Ron Goldman joining from Kognito. Real pleasure to be talking to all of you today and share with you really a case study of work we have done together with the American Academy of Pediatrics to address child obesity. Very quickly, a little bit about us. For those of you not familiar, we are an organization in New York City that's for the past 10 years has been working with many nonprofit and government organizations in looking at how conversations can really drive changes in behaviors. We concentrate in health behaviors, and our approach, as you will see here, is to look at providing people with practice experiences with virtual humans as a way to really learn skills that they can use to drive change through conversations. The areas that we concentrate on when I talk about changes in health behaviors, health is obviously emotional health, is a social health, but also physical health. Really health behaviors such as the ones you're seeing here, which a lot of you deal with in terms of self-protective behaviors, self-care behaviors, healthcare utilization behaviors like adherence, and obviously treatment decisions, diet, and overall just engagement of the individual, the patient in this care, in this case, in the treatment. We've done a lot of work in behavioral health as well as chronic disease, and looked at different audiences from family, veterans, LGBTQ, as well as obviously health providers as well. One of the main emphasis of our company, and Dr. Albright, who's joining us today from Kognito, will talk more about this, is really to look at the evidence behind this. There's a lot of science and research that goes into what is created, but for us as a company, it makes a claim about changing behaviors. We want to be able to actually show that. So you can see here a few quick summaries of a lot of studies that were done to look at this. Simulations and look at their efficacy. We're very proud to be the only company with simulations that are listed on SAMHSA's National Registry of Evidence-Based Programs and Practices. So there is real evidence behind what we're going to show you today as an approach in terms of changing not just skills and attitudes, but actually changing behaviors. So again, we have the opportunity to work with a lot of different organizations, and we will touch more about that as we continue to go. So to go to the challenge that a lot of you on this call obviously face as we look at changing health behaviors, it is a very, very significant challenge. Changing behaviors in general is difficult. Health behaviors introduce a number of additional components that make it even more difficult. And when you think about this, if you look at someone that you're going to meet or someone that you want to influence their health behavior, obviously there are a number of different factors that you need to take into account. Obviously things in their environment, everything from their social support around them, their work-life situation, their economic condition. You got to look at their current behavior and knowledge, right? A lot of the programs out there really look at improving the level of knowledge that the person has about their condition or the risk that they're in. But you obviously have to look at the individual. And what we see often is that, especially on the provider side, is that the first point here, the medical condition of the individual is really dominating the way that they're approaching the situation. Oh, he's pre-diabetes, so this is the things we need to do. Or you have chronic pain, these are the things that we need to do with you. We're really, when you think about how people are motivated to change their behaviors, looking at their mindset, looking at their concerns, What are those barriers for them to change? What are their intrinsic motivations to change, as well as their comorbidity, especially with chronic disease where we know there's a huge amount of comorbidity even with behavioral health issues. All of those has to be taken into account. And that's what makes it very, very difficult, because you've got to really understand the entire kind of ecosystem of that individual to come up with a way to motivate them to change their behavior or their attitude towards something. And current solutions, which obviously have a lot of value out there, from educational programs, many of them done in person, more recently a lot of mobile alerts that you can get on your phone if you are not doing something or if I want to remind you to do something. Obviously communication campaigns and PSAs have been out for many years, as well as different types of incentives, all the way to monetary incentives where we're going to give you a coupon or we're going to give you $5 if you buy vegetables. So all of those obviously play an important component in any strategy for changing behaviors. And our take as a company, and we found a lot of synergy with the AAP in that, is that at the end of the day, conversations are very, very powerful tools to change attitudes and change behaviors. And that our take is that they really has to be involved and has to be part of any comprehensive strategy to change behaviors. And in health, I think it's even more clear because health conversations occurs everywhere. This is not just in the doctor's office. This is now in the pharmacy or in the retail pharmacy. It's at home. It's at school. It's everywhere. So what we're trying to do as an organization, today we'll show you one example, is to really provide these experiences so people are more comfortable and more skilled in having these type of conversations. And I want to turn this now to Glenn, because one of the things that we realized very quickly as we start approaching this is that it still doesn't mean that it's simple to manage these type of conversations, and here is a little bit about why.
Hello everyone, Glenn Albright. Thank you very much for attending, and it's a pleasure to speak with you. What we know from neuroscience is that challenging conversations really involve two separate systems that are intimately interrelated. So we have the cognitive system, which is the thinking part of you, which houses our beliefs, our attitudes, and it's usually a little bit slower to react when you have a challenging or emotional conversation. And that sits alongside the emotional system. And this system is activated when we have a lot of information, especially emotionally laden information coming towards us. It is lacking of really well-based judgments on how to manage a conversation. In fact, if it's stimulated enough, it will activate the fight or flight response. So the idea is to provide the user with strength of the cognitive system, with giving them strategies to increase their frontal lobe executive functioning to have control over this emotional system. And our next slide shows the types of skills that the cognitive system is really assimilating within our conversations. And the first one is under communication, where we have motivational interviewing, which is a empirically based strategy in being able to communicate effectively with patients and other individuals. The importance of developing collaborative treatment plans as an example, trust, empathic listening, pacing a discussion. We know these are all important components in really strengthening that cognitive part of the system. In terms of the cognition part, we have mentalizing, which is key. As a matter of fact, it's a primary component of all successful psychotherapy. For when you're mentalizing, you realize that the person you're talking to is an independent agent. They have their own thoughts, their own feelings, their own view of the world, and that's okay. There's no need for you to be critical, judgmental. Just meet them where they are. And you couple this with empathic accuracy, which is different than empathy. Empathic accuracy is when you know what someone's feeling. Couple that with mentalizing, you can again more effectively understand where they are, communicate with them. And then lastly, in terms of understanding their emotions, empathy, you're feeling what they're feeling, self-regulation and emotional regulation is when you can actually regulate or modulate someone you're talking to, their emotion, because it is a challenging conversation, it is difficult. So you can identify that emotion, regulate it, and also to identify your own emotions and being able to regulate that. This involves or allows you to engage in reappraisal strategy where you can utilize the skills in communication, motivational interviewing, mentalizing to help facilitate that conversation, which will ultimately lead into a change of attitudes, a change in self-efficacy, or you feeling prepared to handle these difficult conversations, and last but certainly not least, a change in behaviors.
And if you look at the different theories relating to how it is most effective to build these type of skills, as well as the motivation, maybe the self-efficacy to actually apply these in real life, it's very clear that role play is the ideal way to do this. Obviously, role plays have been around for many years in terms of a strategy to building communication skills. There's fairly significant amount of limitations and difficulties to do role play in a classroom or in-person setting. And what we are attempting to do here is to really allow you to have these role play conversations in a virtual environment where you will make your own decisions, you will experience the consequences of those, and through that you're learning these communication, this cognitive and this emotional skills that research shows are necessary for you to be able to manage a conversation around changing behaviors. And that can be a doctor talking to a patient with diabetes who is not taking their medication. It can be a nurse talking with an adolescent that is screened positive for substance use about seeking help, or it can be a parent talking to their child about underage drinking. All of those are, in a way, these type of challenging conversations that practice is significantly helpful in building those. So we talked a little bit, and I kind of want to segue into another topic before we bring it back to the case study here. You probably have seen through some of these snapshots that the approach that is being taken here is the use of virtual humans and the use of an experience where you can literally make decisions of what to say to the virtual human and learn through that experience. And a question that we get often, and John, when we first met, that was one of the first questions you had, is like, why virtual humans? So beside the fact that it's cool, why are we using virtual humans and we're not using videos or a different type of approach? So let me talk a little bit about that and maybe begin with just a simple definition of what we mean by a virtual human. You can see here a quote that kind of defines it as a virtual human are automated agents that converse, understand, reason, and exhibit emotions. So you can really communicate with them and talk to them. They're usually 3D in terms of their body, and they perform tasks through dialogue with humans. So that's kind of as a definition. And when it comes to why virtual humans, so first of all, virtual humans, again, has been around for a long time, and there's a very significant body of research looking at their efficacy. There's also a lot of applications that have been used around virtual humans, specifically around the military. More recently, a little bit more as kind of a concierge model in healthcare, where you can kind of ask the virtual human some questions about where to find services or kind of other information-based questions. So there's a lot of kind of research behind it, but really when you look at why you would want to prefer an experience with a virtual human than a video, for example, look at the second paragraph here about instructional benefits. So tremendous amount of research shows that all of us are actually much more comfortable talking with a virtual human than we are with a real person. We feel much more safe to self-disclose information. An interesting research that was done recently at USC showed how patients are going to be much more honest in their answers to a screening tool when it's a virtual human controlled by a computer versus a virtual human controlled by a person. So if you're looking for accuracy in responses from your patients, virtual humans will do a better job. We are going to feel much more comfortable experimenting because we don't feel threatened. We don't feel that we're being judged by this virtual human. They're not reminding us of anyone that give us any sort of transparent reaction about, oh, he reminds me of someone and now I'm going to act in an unnatural way. It increases engagement tremendously if you're looking for experiences that your users will want to engage in or complete. And also opens people to feedback, and that's important because we're helping them learn a new skill. And you can't do that if we're all becoming very, very defensive very quickly. But again, not that simple to build virtual humans. There are a lot of issues with not making them too real, because then you fall into this uncanny valley where it really acts and responds like a video at that point. So there are a lot of very interesting discussions. We can spend probably a whole webinar just on that. There's also great benefits of using virtual humans just because of the fact that you can really personalize the experience. I can give everybody the same type of a role play. I can reduce the cost of updates. So if I need to go back to this virtual human you're seeing on the screen in 5 years, she doesn't age. So I can just make an updates very, very quickly. So it's really very, very helpful in this to really give you the ability to do a private role play experience in the safety, in a safe environment for you. In our case, as you're going to see in the example, we kind of took it to a next level and said, let's not just build 3D, fully animated virtual humans, but let's code them with their own personality, with a memory, give them emotions, so that you get a very, very realistic experience as you're making decisions about what to tell them and in terms of their responses. So they really adapt to your decisions as you go through this. And there's a whole process in terms of graphics and giving them their behaviors and their emotions to really bring them to life. So with that, I want to kind of pause and kind of show you an application of this, hand this over to Allison to walk us a little bit more about kind of what led to this project, especially from the Academy perspective, and then we'll show you an actual demo of how this application can actually be used. Allison?
Sure. Thank you so much, Ron. So I'm sure that I do not need to convince anyone on the webinar. You're all very, very familiar with the fact that childhood obesity is a critical threat to child health. But just as a quick recap, in 2010, more than 1/3 of children and adolescents were overweight or obese. And the obesity rate has more than doubled in children and tripled in adolescents in the past 30 years. So this, of course, has led to significant increases in comorbidities like hypertension and type 2 diabetes, as well as in healthcare costs to address these comorbidities. Next slide. So the key for us really is that the pediatrician plays a critical role here, right? We feel that not only do they see infants, children, and their families frequently for well visits, especially over those first few years of life, but they build longitudinal relationships with these families over the course of 2 decades. And really, no other professional has the capacity to do that. Certainly, there are those who intersect with families frequently during certain segments of childhood, but pediatricians and other healthcare professionals have that longitudinal relationship that really allows pediatricians to establish strong interactions with those families. And so, as I'm sure you're very well aware, pediatricians have the healthcare training needed to support prevention, assessment, and treatment of obesity. They routinely track and monitor growth and weight trends. They counsel families around the establishment and maintenance of healthy, active living habits. And they're critical partners in helping those 30% of children and adolescents who are already overweight and obese. We do know that pediatricians are already counseling families about healthy, active living and about strategies to prevent and address obesity. But as I'm sure many on the phone could attest, our surveys, as well as others, and our needs assessments as well that we have conducted here at the Academy, suggest that while pediatricians do feel that they are competent in providing counseling, they don't feel confident that their counseling alone is effective. And that's really what brought us to Kognito. The person who is currently our president, Sandy Hassink, is also the director of our Institute for Healthy Childhood Weight, and she and a colleague several years ago had seen Kognito demonstrated at a talk and felt that this would be a great way for the Academy to begin thinking about how to support pediatricians in learning more about motivational interviewing. So motivational interviewing, of course, is well suited as an approach to reduce childhood obesity. Our members had requested training specifically to help them motivate behavior change in patients and their parents, specifically around obesity, but of course once you learn the skills, you can apply them to all different kinds of content. As many may be well aware, it's traditionally taught via in-person workshops, taking 2 to 8+ hours. I mean, the gold standard really is multiple days. These in-person trainings are phenomenal, but they aren't scalable. They're hard to standardize, and they're expensive to convene, of course, because they are in person. In addition, they're expensive for the participants because they have to take time away from practice. And we knew that that wasn't terribly practicable, especially as budgets for CME are coming down, and the capacity to leave practice for extended periods of time is becoming less feasible. So because skill practice is really in the essence of building motivational interviewing skills, traditional e-learning approaches just weren't, we didn't feel that they were sufficient. We looked at a few different models and didn't feel that that was something that would work for us. So we decided to partner with Kognito to provide a role-based experience using virtual humans. And our goal was to create, initially, a brief 15 to 20-minute experience that pediatricians and other healthcare professionals can access 24/7 online or via mobile device as an app. So this was designed to be used as a standalone or part of a blended learning strategy. It can be used in either capacity. And Ron, I will go ahead and turn it over to you.
Yeah, I'm going to really touch on this in a minute, but obviously this did not take 24 hours to create. There was a process here that involved about 7 months of work, where we as the company, as Kognito, really took a leading role in everything from conducting the needs analysis to really understand what's needed here, meeting with pediatricians as well as parents to understand kind of their perspective on things. So we went through a whole kind of a design process with figuring out even the virtual humans profile and their behavior and their personality, and then went into the development phase where actually all the scripting and the user experience was conducted, again conducting focus group, and then actually getting to delivering it and some of the analytics that are being run, which we're going to share with you some of that preliminary information. But just to touch on that, obviously there is a significant work behind this, but this is not a 2-year project. This was done in about 6 to 7 months of production and in collaboration with the AAP. Allison, do you want to kind of introduce this, or you want me to continue?
Go right ahead.
Okay. So before I open the actual ChangeTalk, which is both a web resource as well as an app that works on both Android and an Apple device. This resource is actually free. You could see the link at the bottom here where you can go. Don't do it now, but after the webinar, you can go and actually play this, or you can go and download it on your phone. Just search for Kognito or ChangeTalk or the AAP on your phone, and you will find it. So this app was, again, developed as a concise experience that takes about 15 to 20 minutes, designed specifically for pediatricians and other health providers that work with parents and kids. So this is relevant for nurses. This is relevant for nutritionists. And the idea here was to really help them learn how to navigate a challenging conversation with the family and the patient regarding child obesity. How do you use MI to really drive that change in behavior? And as a side effect to it, it also builds your own motivation and your self-efficacy to actually engage in those conversations. This is a CME-approved app, and again, it's made available in collaboration with the AAP that all of you and your audience can take. So let me open this up so you can finally see something actually moving on the screen. And so I'm opening up the web version. And this is what you're seeing in front of you. I'm going to go to the menu. So when you go in, this is what you're going to see as a user on a desktop. You're going to see the menu that briefly will educate you about what is motivational interviewing, what are the basic important skills of MI that you need to know, and then it takes you into the scenario itself. And in the scenario itself, which you are seeing in front of you, you are in this virtual environment. You are assuming the role of the pediatrician here on the left. So we are all going to play her in this conversation. Your goal, and I kind of skipped the backstory, is that this mom, Heather, and her son, Ethan, have been patients of yours for a long time. You have spoken with them about making changes in their health behavior, specifically, obviously, with a child, to reduce the risk of child obesity, but nothing happened. So this is, we heard, fairly common, unfortunately, where you're going to talk to the parent and the child about making changes, and they're like, yes, yes, we're going to change everything, don't worry about it, and then nothing happens. So what we're telling you now is, let's see if by using motivational interviewing and other communication skills, you will be able to do a better job this time. So let's make a few decisions, and then you're going to see how everything kind of works out here. The way I make decisions is through my menu here on the left. Right now I have two tactics that I can choose from. I can ask for permission and say something, you know, will be all right with you if we talk about Ethan's weight, or I can set an agenda. We need to talk about Ethan's weight, or I'm a bit concerned about Ethan's weight. Let's pick that one. Let's see how the mom responds.
I'm a bit concerned about Ethan's weight.
You just said he was doing really well.
Right, and he is healthy now. I'm just thinking about the long term.
Okay, but I mean, I don't think Ethan is that big. That's normal in our family. And anyway, he's a growing boy. He'll probably slim down when he hits his next growth spurt.
Okay, interesting opinion. Let's see the virtual coach coming out and saying, you know, remember that motivational interviewing is patient-centered. Notice how you try to steer the conversation by voicing your own concerns and encountered immediate resistance from Heather. So let me try something else, but let me actually, you can see this bubble here above her head. This is, once in a while, we allow you to listen to the inner thoughts of these virtual humans so that we start sensitizing you to listen or to consider not just what they're saying, but also what they're thinking. So let's see what she actually thinks right now.
And I bet you don't like my weight either.
Okay, and as we heard a lot, by the way, also from parents, is, you know, that they may have their own issues with weight in this case, and you need to be aware of that and consider that. So let me try a different approach. I can jump into providing information. This was very common as we did role plays with a target audience here about, let me just throw a lot of information at the patient, the mom, and hopefully that works out, right? So I can start explaining he's 95% over BMI, which is overweight, and it's a problem. Or I can use some other tactics like reflective listening, for example. In this case, you can say something, you know, so he's big, but you're not worried because that's common in your family, right, which is actually a good tactic. But let's see what else I can do here. I can maybe try to get some information. Let me ask Ethan how he feels about his size.
Ethan, how do you feel about your size?
I don't know. Come on, Ethan. You know Dr. Bosco. You can answer her question.
I'm the biggest kid in my grade.
Okay, what do you think about that?
Some kids, they make fun of me sometimes. I don't like it.
They do? Who does?
Just different people.
What do they say?
Call me Lombardo, Fatso, stuff like that. They make noises when I run.
I can't believe. Why didn't you say anything?
It's not like there's anything I can do about it. It's true. I am big.
Well, there are things I can do about the name calling. I have a few things to say to your teachers, for starters. And tell me who's picking on you, and I will call their parents.
Mom, no. That'll just make it worse.
We'll talk about this later, okay?
Okay, so here we just learn a lot about the child and where they're coming from and what's their mindset in this conversation. And this was literally just 2 questions. So you're about a minute and a half into a conversation, and look at how much information you're able to gain just by asking some open-ended questions, which is obviously a great techniques here, and getting them engaged in this conversation instead of dropping a lot of your opinions on them. And this is part of what we're, in this case, showing the provider, who obviously you can imagine when you come to them and say, we want you to talk to the patient, they might say, well, I don't have time to have more conversations with them. So MI is actually a great technique that has been shown that you can get to better results faster by asking open-ended questions and use other techniques than all the other ones that are normally being used. So we can actually show you that this is not going to take you longer. This can actually take you less time. And remember that we're talking with what we call emotionally responsive virtual humans. So each one of them comes in with a personality, with an emotional state, and therefore each one of us on this call can have a completely different experience with these two individuals depending on the path and technique and the tactics we choose as we go forward here. And the meter above her head is really her willingness to change. And your goal is to get this as to the max as possible. And that's really how you kind of can win this mini game, right? So if you're in this for 10, 15 minutes, the more your goal is to get this up. And that's how you complete this successfully. This is not an experience that you can just click next, 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 and hope that something good happens and you're done. It simply doesn't work like that. So let me continue and make a couple more decisions here. So let me maybe reflect on what Ethan just said, which is obviously very mature of him to reveal that, and it's obviously very important for me to reflect on that one and not just ignore it and move on.
So Ethan, it sounds like it's really tough to be the biggest kid in your class, and maybe you feel like there's nothing you can do about it.
Oh, honey.
It's often possible to get your weight under control by making small changes in diet and activity. What would you think about that?
Ethan, what do you think?
I guess that might help.
Okay, then. Okay. What should we do?
Right, so two things to mention here. First of all, I obviously made some good decisions, so I got them engaged, and now they're willing to listen. It doesn't mean they're going to agree to everything I'm going to say, because I can start sending an agenda here and say, well, we should be reducing his screen time, and they're going to jump right at me and be like, no, that's not going to happen. So the challenges here are continuously happening and confronting you, and it's part of showing that changing behaviors doesn't take 5 minutes, and that building that collaborative decision-making is a process that you need to continuously engage in. But I'm just curious about what she's thinking right now, so let me just click on that before we go back to some other aspects of this webinar.
This will probably never work, but if he wants, I can give it a try.
Yeah, and this is where a lot of great subject matter experts from the AAP really helped us in just putting this into reality and making sure that what we create here is challenging for the end user and not just like a simplification of life. And if you don't like the path that you're taking, you can always click on this undo button here. And if you click on it, it's just like magic. It kind of goes back in time as if nothing happened. You can try a different approach. So again, this ability to play in this conversation, try different approaches, see what works and what doesn't work, and really learning about the best way of achieving it. Allison, do you want to add anything to this as we're going through this demo?
Well, I would like to note that this is something that our members have been highly, highly accepting of and interested. We actually did a study just prior to developing this module to determine whether or not this would be something that health professionals and pediatricians in particular would be amenable to. Would they feel that this was a good way of learning? And overwhelmingly, when presented with sort of the theory of this, they felt that it was something that they would want to do, and that has been borne out as we've seen the uptake come up, which we'll talk about a little bit later. But people are very, very much accepting of this approach.
Yes. Yeah, we have similar experiences when we have done complete research projects with pre-post and follow-ups on other programs, in this case for providers, but a lot of our programs over the years have been for the consumer, the patient, the educator. So this goes well beyond just being a tool to help providers build skills. It's really looking at the entire kind of environment and population that's all around us that plays a role in changing health behaviors. So again, the conversation is here. Other elements from some other reading materials, obviously your CME or other CEU credits, and this is the experience for you. In this case, there is one conversation, In the vast majority of programs, we have multiple conversations so that you get exposed to a variety of personalities, risk factors, et cetera, et cetera. So let me go back to the slides, and Allison, maybe you can take this one. Just talking a little bit about this program has been out now for about 6 months, and a little bit about what you have heard so far, and kind of what has been the the word in the street about this. So I'll let you do this one, please.
Sure. So we launched this in 2014, and we have had extraordinary uptake. As you can see, we've had already 8,320 downloads, and it continues to increase routinely, most of which are actually through mobile devices. And as you can see, that the average rating in the App Store is 4.7 out of 5, which is extraordinary. And then above, you can see that our evaluation results have been very good. So not only have we had 90+% of respondents report that they were very satisfied with using ChangeTalk, they also indicated that they plan to begin to incorporate motivational interviewing into their practice, which is really quite remarkable for a 15 to 20-minute interaction. We have also gotten great feedback as we have exhibited this at various conferences, many of which you probably have been a part of as well in the audience. We've had great uptake at the conferences. We have also had some media coverage as well. And so we at the Academy are just thrilled with the rollout and adoption of this, and look forward to expanding this in the future.
That's great. Yeah, for us, it's obviously been a great collaboration and a project to be involved in. It's really been our first entry into directly kind of a chronic disease, and really open up a lot of potential application of this beyond in the family setting, but also, what happens with the mom once she goes home and she's now motivated to make changes, but the husband is unwilling to collaborate. How is she going to talk to him about getting involved in a positive way in the change that they want to do at home? And so I want to mention just a couple of things, because I see a lot of questions coming in. And we have time at the end here to answer questions. This is being recorded as a webinar, so all of you will get a link to this recording by end of day tomorrow, as well as a copy of the slides. I'm sorry for not saying this at the beginning for anyone who's been taking notes, but you'll get a copy of all of this. So maybe, Allison, I know there's a need to acknowledge the Nestle as supporting this, and then we can go into the questions. If you guys want to start submitting more, we have plenty of time to address them now. Allison, do you want to do the slide?
Certainly. Well, I just want to acknowledge that the Institute for Healthy Childhood Weight gets funding from a variety of different corporate, foundation, and governmental sponsors. But we do want to gratefully acknowledge the founding sponsorship of Nestle for the Institute for Healthy Childhood Weight, and that is actually what provided the resources to develop this module. So we are very grateful.
Great. All right, so we have about 10 minutes to go over some questions. And the first question I'm seeing here is, how much does it cost? So again, this particular app is free, and you can find it at Kognito.com/ChangeTalk. You can also find it on the AAP website. You can go to the App Store and just search for ChangeTalk or Kognito or the AAP, and you can find it, you can download, you can play that. So there is no cost for this particular app. And one of the first questions here, Allison, and this is a timely question, is a question I believe somebody was familiar with your programs, and knowing that you do a lot of work on the family side, not just on the provider, and they're asking a little bit more about what is the work that you're doing with families in terms of child obesity, and what do you see this type of methodology being helpful for them, and in what way?
Well, thank you. That's a great question. We have actually done quite a bit of focus group research around the country to really understand how our messages resonate with families. or don't resonate, as the case may be, and how we can really meet families where they are, particularly in development of healthy, active living habits. And so we've developed a whole foundation of resources around that I'd be happy to share after the fact. When Ron posts this, we can include references to other resources. But as it relates to this webinar, I think a critical next step is really in helping to equip families with the parenting skills to be able to incorporate healthy, active living and habits at home. We know that knowledge is absolutely critical, but that it's difficult sometimes to translate that knowledge into practice. And we feel that this technology would be extraordinary in terms of teaching parenting skills. And Ron, I know, already has some work underway in that arena, which I think is really important.
Great, thank you. The next question is more to us here at Kognito, which is a little bit more about how we work with state agencies. So again, over the past 10 years, and mostly over the last 5, where we have concentrated on health, we have created a kind of a portfolio of online and mobile programs that are being licensed by many state agencies around the country. I believe we're working now with about 20 that are licensing these training programs, experiences, simulations for different settings where they're trying to change health behaviors, both on the K-12 and higher ed, a lot around mental health and behavioral health, but also in hospitals and ER. We've also done a lot of work around supporting veterans with the VA, around military families, around veterans themselves as a peer model in terms of self-help and referral to treatment services. So we mainly work with state agencies, nonprofit foundations, as well as commercial healthcare, where in many cases they are able to take something we already have. Maybe we make some modifications, but then they license it and make it available to their audience. We obviously track usage and can collect data so that you can know whether this is having the impact you want. And then we obviously work on, in partnership, just like with the AAP here, on creating something that does not exist, that we work on together to create, and in many cases also disseminate and put it out there to the audience. There's another question here, Allison, for you in terms of, and I believe you mentioned that, but maybe you can talk more about this, about the interest of pediatricians in taking more time out of their busy schedule to engage in another experience. Have you found that challenging or not? And whether, I guess, this type of an approach is helpful in getting their attention?
That is the million-dollar question, and I'm glad someone asked that. Interestingly, we have found, not only through our work, but through other work that the Academy has done, and I believe that it's been done in general with motivational interviewing, that while it feels like you're spending more time with the patient, it's actually not more time. It's just using the time more effectively. And so it doesn't require adding extensively to your well-child visit or to the visit at hand. Certainly, we are very much supportive of adding additional visits to be able to follow up on this, and in fact are doing some work that if anyone wants to email me, I'd be happy to talk about a little bit further, but with other organizations to really expand access to care so that folks have access to greater visits, both with pediatricians and with dietitians, to be exploring expansion of their healthy, active living habits. But we are very pleased to report that this really does not expand the length of time in the original visits.
Great, thank you. There's some questions here about ChangeTalk and whether it's culturally competent to kind of different groups. And we're going to address that question, and there's actually was a lot of work around that, as well as we're trying to create things that are kind of nationally relevant. One of the advantages of the use of virtual humans is that depending on where you are, and definitely about what's your role, we can adapt the options that you have in the conversations. We can adapt the personality and the responses of the virtual human. Obviously, a dynamic between a social worker and a patient is different in many cases of the dynamic between a doctor and a patient, just like it would be between the wife and the husband if they talk at home, because the husband may be pre-diabetes and is not following the treatment plan. Glenn, you wanted to add something?
This also involves issues of transference and how the virtual human neutrality facilitates dealing with that. As a matter of fact, we just completed a meta-analytic study on 5 of our training simulations that involved over 12,000 users. And when we looked at the data, we virtually found no differences between the cultures, races. As a matter of fact, we were able to gather enough information from American Indians and Alaska Natives to actually publish a paper showing the impact of this training on, in this case, their ability to help students in psychological distress, how to identify them, talk to them, and actually motivate them to seek mental health support services.
Yeah. The next question, I guess, targeted at us as Kognito, specifically within the area of chronic disease, where else do we see this play? I think the list is very long, to be honest. If you think about any chronic disease, whether you already have it or whether you're at risk for it, and it's not just you, it's the people around you that care about you and want to help you, if it's your loved one, or if you're an adolescent, it's people in your school around you, the school nurse, obviously the healthcare providers. All of those individuals should be capable and motivated to have this type of conversations to really help the individual through this process. And so for us as a small company that's really trying to break into the chronic disease area and so far have got great responses, we see a very, very long list. So when people come to us with diabetes, they will come to us with chronic pain. All of those are things of much, much interest to us that we're interested in pursuing. So there's a few more questions here. We're going to address them in through email, just because we're kind of running out of time. But I do want, Allison, if you want to just have a concluding word, and John, if you're here, if you want to just add something before we wrap this up, please go ahead, Allison.
Sure. Well, again, I want to thank everyone for your participation in the webinar. I want to very much thank Ron and Glenn for the opportunity to work with Kognito. This has really been an extraordinary experience for us, and to the point of the question that was just answered a moment ago, we absolutely see this as a critical skill set and a critical modality for teaching motivational interviewing to address all kinds of chronic disease, not simply obesity. So we're really excited about the potential this holds and appreciate this opportunity. Thank you.
Okay. So thank you, everyone. Again, we have recorded this, and we will send you all a copy of the slides and a link to the recording so you can share it with others. And you have our contact information here, and please go ahead, download ChangeTalk, and see how upset you can get the mom. There's actually a number of good options there. So hopefully you enjoyed this, and this was educational, interesting, and we look forward to hearing from you. So thank you, everyone, and thank you, Allison and John, for giving us this opportunity. Thank you.
Thank you,
Thank you, everybody.